Hello, students. I think everything is properly visible and I'm audible to every one of you. Hello, Sannyasi Pandit ji. Okay, a very nice name. Harshit, I remember you. Niyaz, I also remember you. So I hope, good afternoon, pilot. Thank you for the previous class. I hope I am very grateful that you went for the lecture and most of the questions are being asked from there. Now for FMGE, we have a little bit change. For FMGE, we will be discussing pharma in two parts. We will discuss in two parts. So today, we will be starting with half of the pharma. We will finish half of the pharma. And today we will discuss about general pharma, autonomic nervous system, glaucoma, respiratory system, kidney, cardiovascular system, and endocrine. These previous year MCQs of past 5 to 6 years we will be discussing today. On next class on scheduled on Monday, we will discuss about CNS, central nervous system. Next session will be part 2. In part 2, we will discuss about CNS, antimicrobial, anti-cancer drugs, autocoids, GIT, and certain miscellaneous topics we will discuss in part 2. So what is the agenda for today's class? Today we will be starting with all these topics and we will discuss all the previous year MCQs in great detail. Okay. And yes, pilot, my INICET session will also be there. The students who are appearing for INICET, I will be having a class most likely on 13th or 14th of April. The schedule will be sent to all of you students who are eligible for INICET and giving INICET this year. Attend that session. Most of the question will come from there only. Okay. So without wasting, yes, we will be having our I. Okay, Niyaz. Thank you. You have been my student previously also. I'm grateful for that. So I think we can start because your exam is near. After exam, we will talk other things, but this time let's talk business only. Business means we have to just study and focus on our study, nothing else right now. Okay. So I think we can start now. So let's start with the general pharma first. Okay, I'll just change my position a little bit so that, okay, now it's fine, I believe. So tell me, first question, I hope it's visible now. Uh, yep. So which of the following statement about drug is true? So I'll just draw this diagram for you. So suppose this is a drug A, this is the drug C, this is the drug B, this is the drug D, and this is a dose response curve. This is a dose response curve. So anyone who can answer the correct answer? So remember one rule. Whenever you see a dose response curve, we have to identify two things in dose response curve. Efficacy. Efficacy means height. Which has more height is more efficacious. Which drug is more efficacious on dose response curve? Which has more height, because it will produce more response. Okay, on dose response curve. And which drug is more potent? How we identify the drug which is more potent? More potent means which require lesser dose. The drug which is left sided on dose response curve is more potent. So keep this statement in your mind. So tell me, among ABCD, which drug do you think is most efficacious or most effective? Can we say A and D, A and B, they are having more height. So they are most efficacious drug. Now the drug which is on left side will be more potent. So can we say A required least dose? A is more potent than C. C is more potent than B, and B is more potent than D. So potency is determined on the basis of left-sidedness on dose response curve. Keeping this statement in mind, tell me, is drug D most potent? The answer is no, false statement. It is a false statement. Remember, drug D is rather least potent because it is on the right side. Left-sided will be most potent. Drug A and B are having equal efficacy. Yes, we can see they are having equal efficacy. But drug A is more potent than drug B. Yes, drug A is more potent than B. So this statement is a true statement. So one student, I think everyone has answered correctly. That's great. I think your preparation is going very well. Drug C is less potent, or let's say least potent. The answer is no. Drug D is least potent, and drug B has more potency. Drug B has more potency but less efficacy than A. The answer is no. Drug B has less potency as compared to A. So the answer for our question comes out to be B. Very good. Shabash. Let's come to second question. A patient has a history of previous child with Down syndrome. Currently that child patient is on lithium therapy. Lithium therapy, and that mother presents in pregnancy. Pregnancy, the female visit for antenatal checkup. Which of the following condition is the fetus at greatest risk? Anyone? Lithium causes which teratogenic abnormality in fetus? Anyone who can answer? Yes, Hold My Serotonin has correctly answered by releasing his serotonin. So the answer is A, Epstein anomaly. So Epstein anomaly is a type of cardiac malformation which is seen in fetus if a mother is taking lithium. Okay, let's revise all teratogenic drug at one place only. Let's revise our teratogenic drug at one place only. So can you tell me this drug thalidomide? Heard about thalidomide? Thalidomide is a teratogenic drug. It causes phocomelia. Phoco means small, melos means limb. So small limbs. Can you see a diagram of phocomelia? So you can see small limb of a child. Small limb says phocomelia. So this is a side effect of thalidomide. Second drug is lithium. Lithium causes Epstein anomaly. So Epstein anomaly is a type of cardiac malformation in which what happens, the tricuspid valve is not produced properly. Right atria and right ventricle become a single chamber. Fine. Now, which antihypertensive drugs are contraindicated in pregnancy? Any drug that ends with the word pril is absolutely contraindicated in pregnancy. Because they inhibit formation of kidney in fetus, they produce renal agenesis. Then we have warfarin. We will discuss about warfarin later also in great detail in today's session. So warfarin, remember, inhibit vitamin K. Vitamin K is required for bone and cartilage formation. Vitamin D is required, vitamin K is also required. Vitamin K level is reduced by warfarin. Hence in fetus, bone cartilage defect will occur, which you call it as chondrodysplasia punctata. We will come to this question later on. Then we have two anti-thyroid drugs, carbimazole and methimazole. We can see they produce aplasia cutis. Aplasia cutis means the skin of a child is not produced properly. Can we see this part? The skin of the child is not produced properly. That is aplasia cutis. Just like warfarin, tetracycline also produce bone and cartilage defect because they chelate with calcium. Bone, teeth and cartilage defect. Valproate and methotrexate, remember, they produce folic acid deficiency, and folic acid deficiency, we all know, produce spina bifida or NTD, that is neural tube defect. Lastly, phenytoin, anti-epileptic drug produce cleft lip and cleft palate. Cleft lip and cleft palate is produced by phenytoin. I hope you can remember all teratogenic drug at one place. So let's here discuss about which drug to be used in pregnancy, which drug to be avoided in pregnancy. In epilepsy, the safest anti-epileptic drug in pregnancy is levetiracetam. If levetiracetam is not given in the option, then the safest anti-epileptic drug to be used in pregnancy is lamotrigine. Yes, beta, it will be more than enough for FMGE June. Okay. If you have not read previously pharma, read this session. Out of 10, 8 or 9 questions will come from here only. It will be an extensive session. Then which drug is absolutely contraindicated in pregnancy? The most teratogenic anti-epileptic drug is valproate. Okay, now remember valproate is also used as in bipolar disorder to control mania. Hence, bipolar disorder, the most teratogenic drug is valproate. Again, valproate. So the safest bipolar disorder drug in pregnancy is antipsychotic drugs. Antipsychotic drugs are used in bipolar disorder. They are safe. For hypertension, the drug of choice is labetalol. And the drug which is absolutely contraindicated in hypertension in pregnancy is ACE inhibitor, Prilvale drug. I think we can remember this. Now, hyperthyroidism is a tricky thing. Okay, there is no drug of choice, there is no drug contraindicated. So let's understand the books. Previous students have lot of confusion. Hyperthyroidism, first trimester of pregnancy. First trimester of pregnancy, propylthiouracil. Okay, and propylthiouracil is contraindicated in second and third trimester of pregnancy. So propylthiouracil is contraindicated in second and third trimester of pregnancy. Now, in second and third trimester of pregnancy, we give carbimazole or methimazole. Carbimazole and methimazole. But carbimazole and methimazole, they are contraindicated in first trimester of pregnancy. So I hope you have understood there is no single drug of choice for hyperthyroidism in pregnancy. Okay? They both are contraindicated in other trimesters. There is no single overall drug of choice. For hypercoagulation, anticoagulant drug of choice in pregnancy is heparin. You can use any heparin. And the drug which is contraindicated is warfarin. But remember, warfarin is contraindicated only in first trimester. After first trimester, you can give warfarin if a female wants. Diabetes mellitus, the drug of choice in pregnancy is insulin. And apart from insulin, only two drugs are approved in diabetes mellitus in pregnancy. The first drug which has been approved is metformin, and the second drug which has been approved is glyburide. Rest all other anti-diabetic drugs are avoided in pregnancy. Now, which antibiotic is safe in pregnancy? We will write a mnemonic facts, sorry, PCM. And which antibiotics are contraindicated in pregnancy or avoided in pregnancy? Facts. PCM stands for penicillins. All penicillin they end with the word cillin. Cephalosporin, and last drug which can be given in pregnancy is macrolides. Macrolide, remember, they are erythromycin and erythromycin. Okay. Now, which drug to be avoided in pregnancy? First is fluoroquinolones. Second is aminoglycoside like streptomycin, gentamicin, etc. Tetracycline, we discuss bone and cartilage defect. And lastly, sulfonamide. Now in question, you will not get the option of sulfonamide. You will rather get an option of cotrimoxazole. Cotrimoxazole contains sulfonamide, hence it should be avoided in pregnancy. It causes kernicterus, which we will discuss in antimicrobial chapter. Okay, very good. Next is therapeutic index is an indicator of anyone. 2 seconds to answer. Therapeutic index is an indicator of. It is an indicator of 1, 2, 3. Tell me the answer. It's an indicator of safety margin of a drug. It is an indicator of safety margin of a drug. So therapeutic index is an indicator of safety. Potency, the symbol is Km. Efficacy, the symbol is Vmax. Symbol of potency Km, symbol of efficacy Vmax. What is this? Therapeutic index. Very simple concept, very easy to understand. Suppose, sir, you give a drug to your patient. So you give a dose of a drug to your patient and you check response, that in how many percentage of people or patients the response came. So in one dose, the response will come, that is beneficial response. So we call this dose as ED. ED stands for effective dose. But if we increase the dose further, it will lead to toxicity. Toxicity means toxic dose or lethal dose. Now, what is therapeutic index? If we see 50% of the patients in which beneficial response comes, this is known as ED50. And in 50% of the people, when toxicity comes, we call it as TD50 or LD50. That is lethal dose in 50% of people. Last year MCQ, what is LD50? Therapeutic index is equal to TD50 upon ED50. This is the formula of therapeutic index. Very good. So now this is written in front of you. You can easily understand what I was telling you. So therapeutic index, TD50 upon ED50. Now see this diagram and tell me, which drug ED50 and TD50 are near to each other? Drug A or drug B? Which drug ED50 and TD50 are near to each other? Which drug, A or B? Can we say drug A, ED50 and TD50 are near to each other? In drug A, the difference or the margin between ED50 and TD50 are near to each other. So can we say the value of therapeutic index will be less in ED50 and TD50 in drug A, while the value of therapeutic index will be high in cases of drug B? Very simple. So which drug do you think, if we little bit increase the dose, will lead to toxicity? If we little bit increase the dose of drug in this part, it will easily lead to toxicity. So that is why therapeutic index value, if it is very small, we call it as unsafe drug. Hence, therapeutic index, it tells us about the safety margin of a drug. So I think this line is already written. PDF of this notes will be provided to you so that you can remember these concepts easily, and last minute you go through all these questions and blast the exam. Okay. So any drug whose ED50 and TD50 are near to each other, they are known as unsafe drug. Unsafe drug means narrow therapeutic index drugs, and these drugs, they require monitoring. And the list of the drugs which require monitoring, which we call it as therapeutic drug monitoring, is given in front of you, and mnemonic is also written in front of you. How to remember them? Fine, good. Let's move ahead. Now can you tell me from this diagram, what is the value of therapeutic index? I will write this is 8, ED50 is 8, and LD50, lethal dose in 50% of the individual, is 128. Can you tell me the value of therapeutic index? Let's see, it's a very simple question now. So the value of therapeutic index is TD50, which is also known as LD50 upon ED50. So if we divide it by 128 by 8, it will come out to be 16. You can divide it very easily, 128 by 8. So what is the answer for our question? The answer for our question is 16. The answer, very good. Hold my hand, hold by serotonin, very good. The answer is 16. Simple and easy, not a tough thing. So remember this word always. Let's come to the next question. Adrenaline acts via beta 2 receptor, causes bronchodilation. So adrenaline acts by beta 2 receptor, produce bronchodilation. This is the first statement. Whereas histamine acts by H1 receptor, produce bronchoconstriction. Now can you tell me which type of antagonism it is? So remember 2 points. Can we say here the drugs are, these molecules, they are acting on different receptors? They are acting on different receptors, their own different receptor, and they are producing exactly opposite response. They are producing exactly opposite response. So yes, the answer for this question is physiological antagonist. The answer for this question is physiological antagonist. Very good, beta. So let's understand all antagonists at one place. Let's understand all antagonists at one place. There are 4 types of antagonist: physical antagonist, chemical antagonist, physiological antagonist, pharmacological antagonist. Let's understand them one by one. Physical antagonist, it will directly bind to agonist, and it will inhibit the absorption of agonist. So it will directly bind to agonist and it will reduce the absorption of agonist from GIT. Agonist will not enter into the body. The effect of agonist will not come. So what do you think is the classical example? Activated charcoal. Chemical antagonist, it will also bind to agonist, but it will bind chemically. Physical antagonist will bind physically, it will bind chemically. Chemically means acid versus base reaction is a chemical reaction which will lead to chemical neutralization of a drug. So any acidic drug we know in our body, heparin is an acidic drug. The antidote of heparin is protamine sulfate, which is a basic drug. So it's a classical example of chemical antagonist. Similarly, HCl is an acidic substance in our stomach. The basic molecule is antacids. They are chemical antagonists. Next is physiological antagonists. So we already discussed they bind to different receptors and they produce opposite response. So the first example, adrenaline beta 2 produce bronchodilation, histamine H1 produce bronchoconstriction. Similarly, parathyroid hormone, hypercalcemia, calcitonin, hypocalcemia. Similarly, glucagon increase heart rate, beta blocker reduce heart rate. Antidote of beta blocker is glucagon hormone. Similarly, insulin, hypoglycemia, glucagon and growth hormone. Remember growth hormone? Hyperglycemia. Prostacyclin inhibit platelet attachment. Thromboxane A2 causes thrombus formation or platelet attachment. Fine. Now, what is pharmacological antagonist? Very simple. When agonists bind to receptor, it produce effect. Pharmacological antagonists, they will come and block the receptor of agonist. They will block the receptor of agonist. Hence, they are known as blockers. Simple and easy. Hence, they are known as blockers. They are divided into competitive and non-competitive blocker. So let's take an example. Adrenaline acts on alpha and beta receptor. So there is a drug phenoxybenzamine alpha blocker. So it's a pharmacological antagonist. Propranolol beta blocker. It's a pharmacological antagonist of adrenaline. Fine and easy. Good. Let's move ahead. Identify the missing substance marked in X in the given box. First, I will tell you and make you understand. First, this is a receptor with 7 subunit. So it is a G protein coupled receptor. And here we have G protein. I will show you this diagram again. And this G protein is activating adenylyl cyclase. It is activating adenylyl cyclase. The function of adenylyl cyclase is to convert ATP into which molecule? This is the question. Adenylyl cyclase converts ATP into which molecule? So yes, you all are absolutely right. The answer is cyclic AMP. So the answer is cyclic AMP. Now let's understand this part. So this is a G protein coupled receptor, which are also known as metabotropic receptors. They are also known as metabotropic receptor and they require certain second messenger. Now which second messenger they require, I will tell you. Okay, so you can see the shape of this receptor. It has 7 transmembrane protein, 1, 2, 3, 4, 5, 6, 7. So it is just like a snake. This is G protein coupled receptor, which is attached on the tail by G protein, which is attached on the tail by G protein. And this G protein is of various types. It is of 3 types. If it is GS type, it activates one enzyme, adenylyl cyclase. Adenylyl cyclase converts ATP into cyclic AMP. Hence, cyclic AMP level increases by GS type. If it is GQ type, it activates phospholipase C. Phospholipase C breaks down phospholipids. And this phospholipids will be converted into two molecules IP3 and DAG, inositol triphosphate and diacylglycerol. Hence, they increase the level of IP3 DAG. I means inhibitory. It inhibits adenylyl cyclase. Hence, it will inhibit the conversion of ATP into cyclic AMP. It will inhibit the conversion. Hence, it will reduce the level of cyclic AMP. Now, these molecules which we have written, they are known as second messengers. Hence, GPCR, they act with the help of second messengers. Cyclic AMP, IP3 and DAG are known as second messengers. Good. Yes, beta. Now, which of the following drug follows zero order kinetic? Anyone? Anyone? This is a tricky question. The answer is phenytoin. Aspirin can show zero order, but only at very high dose or very toxic dose, which we generally don't give in our patient. But phenytoin shows zero order kinetic even at normal dose. Hence, the answer for our question is phenytoin. Yes, that is why I have told you, no? This is a tricky question. So, if both you have to go, then you will go by phenytoin. If phenytoin is not given in the option, then you go by aspirin. Okay. So, this is the mnemonic WhatsApp. The drug which shows zero order kinetic, WhatsApp. Okay. In WhatsApp, for the last moment, try to remember only ATP. Try to remember ATP. This will solve all your question. Fine. ATP. Now, which drug shows only pure zero order kinetic? Alcohol. Which drug shows pseudo zero order as well as zero order kinetic? Phenytoin. Phenytoin also shows pseudo zero order kinetic. Pure zero order kinetic, alcohol. Now, which drug is not metabolized by acetylation? Yes, beta. You remember right. That's good. Now, which drug is not metabolized by acetylation? The answer for our question is phenytoin. Okay. Now, which drugs are metabolized by acetylation? So, these are the drugs which are metabolized by acetylation. Ship drug, very famous mnemonic, that is sulfonamide, hydralazine, isoniazid, and procainamide. Remember, these two drugs, Dapsone and PAS, they are also sulfonamide only, but we have written separately. They are also sulfonamide. Fine. So remember a mnemonic SHIP DP. Now, which enzyme is required for acetylation? NAT enzyme. NAT stand for N-acetyl transferase. Some people have very good amount of this enzyme. Some people have very poor amount of this enzyme. We Indians have very less or poor amount of enzyme, 70% of Indian. So people having good amount of enzyme, they are known as fast acetylator. People having very poor amount of enzyme, we call them as slow acetylator. These SHIP DP drug, they produce toxicity in slow acetylator. They produce toxicity in slow acetylator. Now the point is their common toxicity is DLE, that is drug induced lupus erythematosus. Drug induced lupus erythematosus is their common toxicity. Next question. You being an ardent researcher in the field of vaccine production, and you are in charge of preparing samples to make a vaccine against a new variant of SARS-CoV. After getting satisfactory result in preclinical study, let's mark this point. You seek to approve the drug into clinical studies. Now you want to approve the drug for clinical study, which require healthy volunteers. Which of the following phase of this clinical studies we refer to? So this is a very simple question but asked in a twisted way. What is the answer? Yes, you are absolutely right. Good. So what is the answer? The answer for our question is phase 1 trial. Fine. So I'll make you understand it very simply that how the drug is made. The drug is made in 3 steps. If you talk about drug discovery, drug is discovered in 3 phases. made in three steps. The first is find a molecule which can become a drug. We call it as drug discovery. Suppose you have found a new molecule which can become a drug, you test this drug in animals. We call it as animal and lab testing. And after animal and lab testing, you do human testing of a drug. You do human testing of a drug. Now remember, human testing of a drug is also known as clinical trial. And animal and lab testing, it is also known as preclinical trials. That is why we call it as preclinical trials, because they happen before we do human testing. First we test the drug in animals most of the time, then we test a drug in human. Now clinical trials are done in phases. Clinical trials are done in phases. So the mandatory phases are, we go in this direction: phase 1, phase 2, phase 3, and phase 4. So we go in this direction. Now remember one point, mark a line here. Mark a line here. Remember, after phase 3 trial, the drug comes into market. After which phase of clinical trial drug comes into market? That is phase 3 trial. So market approval comes after phase 3 trial. So which phase of clinical trial is done after market approval? The answer is, which phase of clinical trial is done after market approval? Which is the answer? Who will answer this question? Which phase of clinical trial is done after the drug has come into the market, after market approval? The answer is phase 4. Okay? So these 4 trial you have to remember for your exam. Yes, there is some phase 0 trial also, which is not mandatory. No one will ask you. Okay? Focus on 1, 2, 3, 4 only for exam. For FMG exam, only 1, 2, 3, 4. Okay? For INICET, I will tell you about phase 0 also, but not right now required. Good. So we will see that phase 1 is done in healthy volunteer, that we will see. So a new drug is introduced into the market. After which phase of clinical trial? What is your answer? What is the answer of this question? A new drug is introduced in the market after which phase of clinical trial? You'll go by which answer? No, no, no. Just read the question again and tell me. A new drug after which phase of clinical trial? Mark, this line is important. Read the question again. Yes, you're right. Nia's absolutely right. Serotonin absolutely right. So the answer is phase 3 trial. So the answer for our question is phase 3 trial. Understood this point? The answer is phase 3. So let's understand all phases of clinical trial just one by one, very fast. Very important topic. Phase 1. First time we are doing human testing. What is our main purpose? To check efficacy or to check safety first? First purpose is to check safety in phase 1 trial. Safety. So it is known as human safety and pharmacology trial. We do in very less number of healthy humans. We do in healthy humans. 10 to 50. It is open label. Open label means no blinding. Open label means no blinding. And what we check? We calculate the dose of a drug, that up till how much dose the drug is safe. That safety limit is known as maximum tolerable dose. That safety limit up to which the drug is found to be safe is, the name can tell you easily, maximum tolerable dose. Now, as we are not testing this drug in patient, we are testing this drug in healthy human, we cannot find efficacy of a drug. Whether the drug is effective or not, this can only be determined in patients, not in healthy individual. Hence, phase 1 trial is not done for, very commonly asked question, phase 1 trial is not done for efficacy of a drug. Understood this point? Good. Now, after you have found maximum tolerable dose, the safety limit, now we will check the drug in patient. We find efficacy, phase 2 and phase 3 trial. In phase 2, we explore the efficacy. Efficacy is known as therapeutic effect, therapeutic exploratory trial. And in phase 3, yes, blinding is done to remove bias. Even randomization is also done to remove bias. You must have learnt in TSM. Randomization is done to remove selection bias. Blinding is done to remove interviewer and observer bias. Okay, you are right. So phase 4 is done after the drug comes into the market. We don't know how many patients are taking our drug in different areas. We cannot make a patient blind, and we find out rare or missed side effects in phase 1 and 2 3 trial are confirmed in phase 4, and if the drug is found to be toxic, we remove the drug from the market and the drug gets banned in which phase of clinical trial? Phase 4 clinical trial, the drug gets banned. Understood this point? Good. Let's the session, don't worry about that. The questions will be different for INIC. I will be teaching you more about anti-cancer drugs there. Okay? So anyone who can tell me the answer of this question? I'm waiting for the answer. The answer of the question is increase renal blood flow. Yes, serotonin is right, Niaz is right. But remember, fine, good. Can we move ahead? I hope everything is fine. Let's tell me the answer of this question. Now we have already discussed the we have already discussed the answer of this question somewhere. Anyone who can tell me the answer? Anyone who can tell me the answer of this question? A lady was stung by many bees. She developed breathing difficulty, probably because of bronchospasm, asthma, and hypotension. That means she is going into shock. Asthma plus shock is equal to which type of shock? Anaphylactic shock. Asthma plus shock is which type of shock? Anaphylactic shock. Do you agree with this point? Yes, you're absolutely right. Great. The answer for our question is adrenaline. I will tell you why not others. I will tell you. So adrenaline, where it is used. The uses of adrenaline is also known as epinephrine. What is another name of adrenaline? Adrenaline is also known as epinephrine. Also known as epinephrine. Remember this first basic concept. First use anaphylaxis. What is the dose of epinephrine or adrenaline? We take out from this vial, we take out zero point 0.5 ml of which concentration? 1 ratio 1000. 1 ratio 1000 is also known as 1 milligram per ml. 1 milligram per ml is also known as 1 ratio 1000, and we give intramuscular injection of adrenaline in anaphylaxis. Why we give? Because adrenaline acts on beta 2 receptor. Because acting on beta 2 receptor, remember first point, it produces bronchodilation. Second reason, it inhibits histamine release from mast cell. And that is why asthma will not occur, because any allergic reaction, there is massive histamine release from the mast cells. Good. Now here remember, Remember one point: norepinephrine and dopamine, they they do not act on which receptor? Norepinephrine and dopamine, they do not act on beta 2 receptor. Hence, they are not used in or not effective in which type of shock? Anaphylactic shock, which is also known as anaphylaxis. Anaphylactic shock is also known as anaphylaxis. Second is cardiac arrest. Second use of epinephrine is cardiac arrest. In cardiac arrest, we give double the dose, 1 ml, and more diluted form. Instead of 1 ratio 1000, we give 1 ratio 10,000. Understood this point? And what is the route? Not intramuscular. Cardiac arrest as an alternative to epinephrine. Okay. Yes, the video got buffered shortly. Okay. Video got buffered. Okay. Let me check if there is some issue out there. Let me check if there is some issue out here. I think now, don't worry. Everything is recorded. If you have skipped anything, don't worry. It will be provided to you in video lectures. Plus, the things I am writing here, the PDF of this written, my handwritten PDF will be provided to you. Okay? Don't worry. Don't take any stress right now. Okay? We are there with you. Okay? Let me. Just give me 1 second. Just give me 1 second. It is the just खोल दो डिवाइसेस बंद कर दो चेक करना ठीक है ना यहाँ से सब खुले रखो I think right now it's fine. Everything is fine right now. I think from my side everything is fine. My side everything is fine. Let me check. Let me check. Give me beta 1 second only. I'll just check why it is buffering. Hello? अरे बफर क्यों हो रहा है दोस्त? तो इसको ठीक करो. कितनी देर लगेगी? हेलो? इसे ठीक करने में कितनी देर लगेगी? हैं? 1 सेकंड 1 मिनट से ज़्यादा ना लगे. बच्चे बैठे हुए हैं. ठीक है? 1 मिनट में फटाफट कर दो इसे. बच्चों को प्रॉब्लम हो रही है उसको ठीक बफर नहीं होना. फटाफट कर दो. मैं भी बैठा हूँ बच्चे भी बैठे. I think we can start again. Yes, you all are ready. Fine. Let's come to the next question. Tell me the answer of this question. A 65-year-old patient. Hello. A 65-year-old patient presented with dribbling of urine with urgency. So tell me, bacha, patient is very old. Patient is very old. And the patient is having. Yes, you all are ready. And the patient is having difficulty in passing urine. Okay. So can you tell me which disease the patient is suffering from? Which disease the patient is suffering from? I think some prostate size has been increased. BPH. He was started on prazosin therapy. Prazosin therapy, but the patient developed postural hypotension. Now remember, postural hypotension will develop because of vasodilation. If the blood vessel will dilate suddenly, it will lead to. So tell me which is the better alternative drug for this patient which will not produce vasodilation. So which drug we will give which will not produce vasodilation? The answer for this question is, I will explain you shortly, is tamsulosin. So what is the answer of our question? Yes, Amit, PK, you all are absolutely right. So let me explain you now. Let me explain you that there are two types of alpha receptors. Two types of alpha receptor, alpha 1A and alpha 1B. Now alpha 1A, it is present in bladder. There is a sphincter in bladder known as IUS, internal urethric sphincter. So remember, if you block this alpha 1A, it will lead to opening of sphincter, internal urethric sphincter, and urine will pass out. Urine will pass out. Understood this point? Hence, it is given in the treatment of BPH. Fine. Alpha 1B, it is present on blood vessels. And if you block alpha 1B, it will lead to vasodilation, and vasodilation will lead to hypotension. Fine. Now we have a class of drug which will block both alpha 1 and alpha 2 receptor. The drug which block both, they will end with the word zosin. They will end with the word zosin, like prazosin, terazosin, elfuzosin, which we have told. Now we have a drug which will only block alpha 1A receptor. The drug that will only block alpha 1A receptor, it will end with the word osin. Z word will not come. Z word will not come. Only osin word will come. Here zosin word will come, which will block both. And here only osin word will come, the drug that will block only and only alpha 1A. Understood this point? So see the names of the drug. Selective alpha 1 blocker, 1 only, A and B both. Okay, prazosin, terazosin, elfuzosin, doxazosin. So they are given for BPH because they block alpha 1A. They are given for the treatment of alpha hypertension also because they block alpha 1B. But what is their side effect? Because they act on alpha 1B, these drugs they produce postural hypotension, which is known as first dose effect. Only remember this point. Just remember prazosin, it is also used in scorpion sting. It is also given in scorpion sting to control hypertension and pulmonary edema. Fine. Now we have selective alpha 1A blocker. Z word will not come. They will only end with the word osin. Tamsulosin, silodosin. What is their advantage? The advantage of this drug is no risk of postural hypotension. Why there is no risk of postural hypotension? Because they do not act on They do not act on alpha 1 B receptor, hence no risk of postural hypotension. So we can see this is a bladder and the prostate size has been increased. Hence, in the treatment of BPH, we give two types of drug. One, to open IUS. The drug of choice is tamsulosin or silodosin. The second drug is reduce prostate size. We have to also reduce prostate size in BPH. To reduce prostate size, we give finasteride or dutasteride. To reduce prostate size, we give finasteride or dutasteride. These drugs are known as 5 alpha reductase inhibitor. These drugs are known as 5 alpha reductase inhibitor. They inhibit the conversion of testosterone into dihydrotestosterone, because dihydrotestosterone is the active form of testosterone which causes prostate size increase. Hence, we inhibit the conversion of testosterone into dihydrotestosterone, finasteride, and dutasteride. Very good. Next question, let's see who can answer. I think it has been repeated. Now tell me the question, this one. Very commonly asked question and very simple now. So it's a follow-up question which was asked in FMGE exam. That is why I have put this question, so that now you will never forget. We already know the answer, alpha blocker. Answer is alpha blocker. And this postural hypotension by alpha blocker is also known as first dose effect, because it is seen when we first time start alpha blocker. When we first time start alpha blocker. So like example, prazosin. Prazosin. Fine. Next question. Which of the following is the mechanism of action of methyl dopa? Anyone? Anyone who can tell me the answer? So what is the action of methyl dopa? The answer of our question is agonism at alpha 2 receptors. Agonism at alpha 2 receptor. Let me tell you. So if you talk about anti-adrenergic drug, the drug which reduce sympathetic activity, they are of three types. I'll tell you how to remember them. Suppose sir, this is a neuron. This is a neuron, and this neuron is releasing norepinephrine. When norepinephrine is released, it acts on postsynaptic receptors. And in postsynaptic, we have alpha 1 and we have beta receptor. So we have two types of drug, alpha blocker and beta blocker. So first type of adrenergic drug is, anti-adrenergic drug is alpha blocker, and second type of anti-adrenergic drug is beta blocker. And can you tell me, alpha blocker and beta blocker, they act on presynaptic area or postsynaptic? They act on postsynaptic receptor. Now, in presynaptic neuron, which is releasing norepinephrine, we have alpha 2 receptor. The neuron which is releasing norepinephrine has alpha 2A, and if you stimulate this alpha 2A receptor, it applies a brake. It inhibits the release of norepinephrine. It will inhibit the release of norepinephrine. And the third type of drug, which is anti-adrenergic drug, is alpha 2A agonist. We call it as alpha 2 agonist. I hope you have understood. So alpha 2 agonists, they inhibit the release of epinephrine, norepinephrine like substance from nerves. So what are the drugs we have? These are the drugs we have in alpha 2 agonist. The mnemonic is CD tag. Remember the mnemonic? CD tag. It's a commonly asked question. First is clonidine, dexmedetomidine, tizanidine, and this was the question which was asked, that was alpha methyl dopa. The actual name is alpha methyl dopa. The question asks only methyl dopa, but the actual name is alpha methyl dopa, and lastly guanfacine. So these are the drugs we have in alpha 2 agonist which act on presynaptic receptor. They act on presynaptic receptor and they decrease the release of norepinephrine. They decrease the release of norepinephrine. Fine. Next question. A drug that causes fall in elderly patient in hypotension. So again we know the answer is prazosin. Let's skip to the next question. Beta blocker are used in all of the following condition except. Now tell me the answer of this question. Beta blockers are used everywhere except. Beta blocker are used in all of the following situation except. Yes, beta PIH I will tell you in cardiovascular system shortly. Which drug to be given in pregnancy, not to be given in pregnancy, we will discuss. What is the answer of this question? Beta blocker are not used in AV nodal block. Beta blocker are not used in AV nodal block. Okay, so let's talk about beta blockers. So remember, beta blockers, they are mainly used when they block beta 1 and when they block beta 2 or beta 3. There are three receptors. So these are the uses. Fine. Let's see, when we block beta 1, what are the uses of beta blocker? When we block beta 1 is present in heart and blockage of beta 1 suppress heart. Because it suppresses heart, beta blocker are the drug of choice for the treatment of tachycardia when the heart is beating more. Stable angina, because it will reduce heart rate, which will reduce oxygen demand. Hence, angina and MI, drug of choice is beta blocker. Beta blocker are the drug of choice for HOCM, that is hypertrophic, obstructive cardiomyopathy, and CHF, chronic heart failure. But because beta blocker, they suppress heart, what is their side effect? They produce bradycardia. Why they produce bradycardia? Because they inhibit SA node. They produce heart block. Why? Because they inhibit AV node. Fine. Now second beta blocker is kidney. And in kidney, beta blocker, they inhibit renin release. So beta 1 receptor is present in two areas. One is heart, second is kidney. In kidney, they inhibit renin release. Renin normally increases blood pressure. Hence, beta blocker are given in the treatment of hypertension. So what is their side effect? The side effect of beta blocker is hypotension, but very less commonly seen. Okay. Second use. Beta blocker, if you want to block beta 2. If you want to block beta 2, remember propranolol is a drug of choice when you want to block beta 2 receptor also. Because propranolol is a non-selective beta blocker, it blocks beta 1 as well as beta 2. So what is the uses of propranolol? Propranolol is a drug of choice for mnemonic is 4P heat. 4P heat. First P, prophylaxis of migraine, drug of choice propranolol. To control tachycardia and pheochromocytoma, performance anxiety, let's say tomorrow you have exam and you have not bought a book yet, portal hypertension. Hemangioma, drug of choice is propranolol, essential tremor, akathisia, and thyroid storm. One more reason why propranolol is given in thyroid storm, because propranolol also inhibit peripheral T4 to T3 conversion. So peripheral conversion of T4 to T3 is also blocked by propranolol. Is also blocked by propranolol, one of the reason used in thyroid storm. Okay. Yes, we discussed Amit that point in last slide. 5 problem 1 solution. Yes, you remember. So this is the summary which we have made. Now, if you block beta 1, bradycardia and AV node block, we know. Hence, beta blocker are contraindicated in bradycardia and AV nodal block. But if you block beta 2, propanolol is contraindicated in asthma and COPD. Beta 2 blockage leads to vasoconstriction. It is contraindicated in vasospastic disease like Raynaud's disease and angina. And beta 2 blockage leads to bad effect in diabetes and dyslipidemia. The last point with beta blocker is, what is the antidote of beta blocker? If beta blocker is producing bradycardia, let's say, what is the antidote? Let's say if beta blocker, atenolol, propanolol are producing bradycardia, heart block, the antidote for beta blocker is glucagon hormone. Antidote is glucagon hormone for beta blocker toxicity. Now tell me about this question. A patient presented with weakness of limb muscles, especially in evening. The patient is normal in morning, and as the day gradually progresses, the weakness increases. And this symptoms improved by hydrophonium test. Simple question now. The person is likely to be suffering from. The person is likely to be suffering from. Likely to be suffering from. What is the answer? The answer of our question is myasthenia gravis. So this is the best answer. But remember, this can also be true. This question has been asked in FMG. Sometimes. It can also become positive in Lambert-Eaton syndrome also. But you have to go with the best answer. The answer of choice is myasthenia gravis. So let's see what is the treatment of myasthenia gravis. So if a patient of myasthenia gravis comes to you, which drug you give for symptomatic treatment? We give neostigmine. And if you there is another option, pyridostigmine, which is a longer acting drug. With this drug, any one of the following drug, you add a drug atropine. This is the drugs combination we give for the treatment of muscle weakness or symptomatic treatment. Definitive treatment is reduce this antibody production. Because myasthenia is an autoimmune disease, antibodies they block receptors of acetylcholine, which leads to paralysis of muscles. So definitive treatment is corticosteroid. Which corticosteroid we start generally? Methylprednisolone or prednisolone. It is for induction. Then after that we maintain the patient on azathioprine because long-term corticosteroid will produce harmful effect. Now if a patient came to emergency and patient is not able to breathe, emergency, diaphragm has been paralyzed, this is known as, this emergency is known as myasthenic crisis. So you have to remove antibodies very fast from the blood. So in myasthenic crisis, you change the plasma of the patient, you do plasmapheresis. You change the plasma of the patient where antibodies are getting circulated, you do plasmapheresis, or you can give intravenous immunoglobulin. These immunoglobulin, they will bind to those circulating autoantibodies and neutralize them. Now, which drug is given for diagnosis of myasthenia gravis? The eyes will suddenly open, the symptoms will improve, that is hydrophonium. Hydrophonium injections are given for diagnosis of myasthenia gravis, and this test is known as tensilon test. This test is known as tensilon test. Fine? Very good. Now, a patient on myasthenia gravis presents with increasing muscle weakness. Which of the following drug is used to differentiate between myasthenic crisis from cholinergic crisis? Anyone? Again, the same answer, hydrophonium. Now, what do you mean by myasthenic crisis versus cholinergic crisis? First point is myasthenic crisis. Myasthenic crisis means there is excess of antibodies. Excess of antibodies leads to flaccid paralysis. A person will have symptoms of weakness. But suppose you have given overdose of neostigmine. Let's say you have given overdose of neostigmine. Can we call it as cholinergic crisis? Cholinergic crisis means you have given overdose of neostigmine. Can we say now there is excess of acetylcholine which is increased by neo, and this will lead to spastic paralysis. So both will lead to paralysis and the patient will have a symptom of weakness. How to differentiate? The problem is the muscles which are involved are very small muscles of eyes and very small muscles of hand, and hence you cannot see whether it is a spastic or a flaccid paralysis. So what we do? We give hydrophonium again. Hydrophonium will lead to increase in acetylcholine level just like neostigmine. So here there will be improvement because it will compete with antibodies and overcome the effect. Acetylcholine will compete with the antibody and overcome the effect. But here already acetylcholine is excess. There will be worsening. There will be worsening. So that is why hydrophonium is given to distinguish between myasthenic crisis versus cholinergic crisis. I hope you have understood this concept. I hope you have understood this concept. If you have understood, raise your hand. Okay? Chalo. After eating an unknown plant, a child presented to emergency in comatose state. Comatose, let's mark it. And unknown plant, this is a point we should remember. The pupils were dilated. That means there is mydriasis. The skin was dry. The body temperature is raised. And the heart rate is high. Fine. This sign and symptoms, they occur with the intake of which of the following substance? Anyone? Anyone? Dhatura, poppy, poppy means opioid, mushroom, cannabis. What is the answer? The answer is Dhatura plant. The answer of this question is Dhatura plant. Why? Because Dhatura plant contains one anticholinergic drug, that is atropine. So these are the features of atropine poisoning. And atropine is an anticholinergic drug. So atropine, it is obtained from natural plant. Which plant? Atropine is obtained from first belladonna plant, second Dhatura plant. So these are the two plants from where we obtain atropine. Fine. There is one more similar brother of atropine known as hyoscine, which is also known as scopolamine. It is obtained from Hyoscyamus plant, Hyoscyamus niger plant. Plus we have other drugs in anticholinergic. Remember, tricyclic antidepressant, antihistaminic and quinine, they can also lead to atropine-like side effect. Now remember what are the features of atropine poisoning. In atropine poisoning, there is decrease in all body secretion. First point. Second point, there is increase in heart rate and the pupils are dilated. If you can remember these three words, these are the features of atropine poisoning. Now, why not opioid poisoning? In opioid poisoning, all body secretions will be reduced. Heart rate will also be reduced. and pupils are constricted. There are pinpoint pupil. There is pinpoint pupil. Okay. That is why it is not opioid poisoning. Now, let's say there is decrease in sweating. There is decrease in sweating. Decrease in sweating leads to hyperthermia. Fine. Hyperthermia or raised body temperature, which was mentioned, will lead to vasodilation. Vasodilation will lead to flushing, dry eyes, dry mouth, urinary retention, constipation. That means again all the body secretions are reduced. Tachycardia. Now in brain, it causes memory loss and dilated pupil mydriasis, sign of atropine poisoning. Antidote of atropine we all know is physostigmine. Antidote for treatment of atropine poisoning, physostigmine. Okay. A farmer presented to emergency. So this word farmer is important. Emergency with garlic odor. Pinpoint pupil, that means there is meiosis and excessive secretion. Now tell me, excessive secretion. Which of the following is the drug of choice for the treatment? Now remember, this is a classical case of organophosphate and carbamate poisoning. Now why it is not opioid poisoning, I will tell you. In carbamate and opioid poisoning, all secretions are increased and pupils are constricted. While in opioid poisoning like morphine, all secretions are reduced and pupils are constricted. So now tell me, you will go by which option? Organophosphate carbamate poisoning or opioid poisoning? We will go by secretions are more, we will go by organophosphate and carbamate poisoning. What is the treatment? The antidote for carbamate and organophosphate poisoning is atropine. The antidote for opioid poisoning is naloxone. Okay? And sometimes we add oximes. Oximes are only given in OP poisoning. If it is only OP poisoning, we give oxime, but overall drug of choice is atropine. I will tell you the reason shortly. So the answer for our question is atropine. Fine? Shabash. So let's see the treatment of organophosphate and carbamate poisoning. So the overall drug of choice is atropine. We give generally 2 milligram per kg repetitive injection. Overall drug of choice. And it is a life-saving drug in both poisoning. Now in OP poisoning, we add oxime. Here, oximes are contraindicated like pralidoxime. So in organophosphate poisoning, we add oximes. Fine. So this is the treatment of organophosphate and carbamate poisoning. Let's move ahead. Tell me the answer of this question. A person presented to emergency with comatose state after consuming some unknown poison. Excessive sweating is apparent on examination. There is bradycardia. The BP is less. Which of the following is the antidote? So remember the clinical feature, mnemonic for the clinical feature for OP and carbamate poisoning is dumbbells. And this dumbbells occurs because of increase in acetylcholine level by OP and carbamate. D for diarrhea. I told you all secretion will be increased. Urination, meiosis, which is known as pinpoint pupil. Bradycardia, which is given in our question. Bronchospasm, emesis, vomiting, lacrimation, salivation, and sweating. So you can see bradycardia is there, excessive sweating is there. What is the antidote? The antidote is atropine. Antidote is atropine. Next question. Which of the following drugs is considered as a first line therapy for the prophylaxis of motion sickness in adults? Anyone? Anyone? What is the answer? Prophylaxis of motion sickness in adults. What is the answer? The answer for our question is very simple, promethazine. So just remember for a moment, promethazine is an antihistaminic drug, first generation. Fine. Ondansetron, any drug that ends with the word cetron is a serotonin blocker. It is 5-HT3 antagonist. It is the drug of choice for chemotherapy induced nausea and vomiting, which we will discuss in next session part 2, radiotherapy induced nausea and vomiting. Metoclopramide and domperidone, they are dopamine blocker, and this domperidone is given in the treatment of levodopa induced vomiting. While both drugs are given in the treatment of gastritis, because gastritis causes vomiting, okay, GERD, to prevent aspiration. So these concepts I will tell you in next part why it happened. Fine, let's move ahead. Let's discuss about motion sickness. Sir, motion sickness starts from ear. From ear, these are the three semicircular canals. One nerve arises known as vestibular nerve. This vestibular nerve goes to cerebellum. From cerebellum, it goes to CTZ area, which leads to nausea and vomiting. This is how motion sickness starts. Now, on this vestibular nerve, remember we have two receptors, M1 and H1, which stimulates this vestibular nerve. Which stimulates this vestibular nerve. This leads to nausea and vomiting. Hence, in motion sickness, we have two types of drug. The first one will block M1, second one will block H1. So we have antimuscarinic. Antimuscarinic is the overall drug of choice, that is hyoscine, also known as scopolamine, we discussed. And we give antihistaminic. Remember, in ear, we don't have serotonin or dopamine receptor. That is why we don't use metoclopramide, domperidone, and the third drug, ondansetron, and antihistaminics like promethazine, diphenhydramine. So promethazine was the answer. Cyclizine, meclizine, and the last drug, cinarizine. Okay, last drugs, cinarizine. These are the drugs we give for the treatment of motion sickness. I hope you have understood. Next is a 12-month-old baby is brought to your clinic and you have to give a cycloplegic agent for this patient. Which of the following drugs would you prescribe? Anyone? Now the point is, just remember, cycloplegic, first point, 12-month-old baby. Okay? These 2 points are important. Now tell me what is the answer. Anyone who can tell me the answer? Anyone? I am giving you 2-3 seconds. It's a tricky question. but it has been asked in your FMG exam. So I'm waiting for the correct answer. Let's see who will give me the correct answer. Now the answer of choice is atropine eye ointment. The answer is atropine eye ointment. What is the concentration? 1% concentration. Yes. Not atropine orally. See, in eye you will not give. Now, why not tropicamide? Because tropicamide is not strong enough drug. So let's talk about what are the different drugs we have in eye. First class of drug in eye is miotics. Remember, miotics, they contract one muscle in iris. You can see this iris and you can see this muscle which I have marked now. You have seen this muscle? This muscle is known as sphincter pupillae. So this muscle is known as sphincter pupillae. I'll just mark it for you. This muscle. So this muscle is known as sphincter pupillae. Hence, the size of the pupil will reduce. So the drugs are pilocarpine, use glaucoma, use glaucoma. Second is cycloplegic passive mydriatic. Cycloplegic means they will relax ciliary muscle. Hence, there will be loss of accommodation. Lens will not change the thickness. And passive mydriatic means they will paralyze sphincter pupillae. They will paralyze sphincter pupillae, which will lead to mydriasis. Now, what are the drugs we have? We have ACTH, 4 drug. We have 4 drug ACTH. A for atropine, C for cyclopentolate, T for tropicamide, and H for homatropin. So only these drugs are cycloplegic, and among them they are given as an eye drops atropine 1% ointment. It is the drug of choice to produce cycloplegia in children. Cycloplegia in children. Now I'll come back to this question. Remember, atropine orally is contraindicated in children. Generally avoid because it can lead to hyperthermia. So generally we avoid oral atropine in children. It leads to hyperthermia. Lastly, active mydriatic. Active mydriatic, see this eye, you can see this part of the iris which I am marking. This another muscle which we can see. These muscles, they are known as radial, these are known as dilator pupillae. So active mydriasis means you contract dilator pupillae. And the drug of choice is phenylephrine. The drug of choice is phenylephrine, which is given for fundoscopy in adults. I hope you have understood the names of the drug and what does it mean: active mydriasis, passive mydriasis, and meiosis. Okay, so these points you have to remember. Next question. An elderly male presents with the symptom of dementia and diagnosed with Alzheimer disease. You know the level of which neurotransmitter is reduced? Recent question in FMGE. Can we say the level of acetylcholine is reduced? Because acetylcholine increases memory. Hence, in Alzheimer disease, there is Dementia. There is dementia. Good. So let's see what are the drugs we have for Alzheimer disease. The first class of drug for Alzheimer disease we are having is anticholinesterase. Anticholinesterase, they will increase acetylcholine level in brain, and these drugs will increase memory. So what are the name? We can remember a mnemonic T Duggar. T Duggar. Among this, T has been banned. Which drug is not used nowadays? We don't use this tacrine because it is hepatotoxic. It has been banned. So which drug is used? We use donepezil, galantamine, and rivastigmine. And overall drug of choice for Alzheimer disease is donepezil because it will increase acetylcholine level in the brain. If it is not controlled by anticholinesterase, then we add a drug memantine. How we can remember memantine? MEM. Memory. MEM means memory. It increases memory. A for Alzheimer's disease. So which drug increases memory in Alzheimer disease? Memantine. What is the action of memantine? It blocks glutamate receptor. The receptor of glutamate is NMDA receptor. It blocks NMDA receptor of glutamate. Glutamate damages neuron, leads to memory loss. Lastly, two new drugs recently got approved for Alzheimer disease. The first is aducanumab. Mab word is coming, it's a monoclonal antibody. Second is lecanemab. So both drugs are ending with the word mab. Now see the word AND. AND means Alzheimer disease. Now these monoclonal antibody, they block or they are anti beta 1 amyloid. They bind to beta 1 amyloid protein in the brain and help in removing that beta 1 amyloid from the brain, because in Alzheimer, this abnormal beta amyloid protein gets over deposited, which leads to neuronal death because of pressure. Because of pressure. A new drug recently got approved is lecanemab. It's a new drug recently got approved for Alzheimer disease. Earlier it was aducanumab. Now a new drug is lecanemab also. So this is the drugs which have been approved for Alzheimer disease, written in front of you. Remember it properly. Let's move ahead. So what is the drug of choice for Alzheimer disease? Recall and tell me now. The drug of choice for the treatment of Alzheimer disease now we know is donepezil. You know the drug name? Donepezil is the drug of choice for the treatment of Alzheimer's disease. Fine. It is the drug of choice for the treatment of Alzheimer's disease. Very good. Tell me next question. Adverse effect of orlistat. Question has been asked. What is orlistat? I will tell you, orlistat is an anti-obesity drug. It's an anti-obesity drug. And orlistat is a OR, oral, LI, lipase. Stat means inhibitor. So can we say it will inhibit the breakdown of fats in GIT? And if fats are broken down in GIT, fats will not be absorbed into the blood. If fats are not absorbed into the blood, what will happen? Weight loss will occur, but fats will be excreted out in feces. Excessive excretion of fat in feces is known as ketoria. Excessive excretion of fat in feces is known as ketoria. Let's talk about approved anti-obesity drug. Anti-obesity drugs are approved anti-obesity. First is mifentermine. Mifentermine is a sympathetic drug. It increases sympathetic activity in the body. Hence, the person will not love to eat anything. Topiramate with topiramate. Topiramate is an anti-epileptic drug which causes weight loss. Which anti-epileptic drug causes weight loss? Topiramate. Second, bupropion. Bupropion is an antidepressant which causes weight loss. Which antidepressant causes weight loss? Bupropion. Just like topiramate, zonisamide is also an anti-epileptic drug. They both are anti-epileptic. Liraglutide and semaglutide, they are recombinant form of GLP-1, that is glucagon like peptide, which are used in treatment of diabetes mellitus. They also produce weight loss. Liraglutide is given by injection. This is a recent question. While semaglutide is given orally also. Orlistat and cetylistat we already discussed. They are lipase inhibitor. They produce steatoria. Fine. So now you have the list of anti-obesity drug in front of you, which are also known as anorectic drugs. Okay. Next question. Beta blockers are avoided in all of the following condition except, I think this part we have already discussed. The answer is glaucoma. Beta blockers are given in the treatment of glaucoma. This part we have already discussed. So let's see what are the different drugs we have for glaucoma. Okay. So in glaucoma, the drug of choice is prostaglandin F2 alpha agonist like latanoprost, bimatoprost, latanoprost, bimatoprost. So these drugs, they increase uveoscleral outflow, which you will learn in ophtha in more detail. Second drug is beta blocker like timolol, cartiolol, pitaxolol. They decrease aqueous secretion from eyes. Third drug given is alpha agonist. They have all action. All action means both above action. So ABD, apraclonidine, trimonidine, epivephrine, epivephrine. Okay, dipivephrine. Good. Then we have carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor. Remember, they will end with the word zolamide. Heard about any drug zolamide? Brinzolamide, dorzolamide. These drugs, just like beta blocker, reduce aqueous secretion. Lastly, miotics like pilocarpine, isostigmine. These drugs, they open iridio corneal angle. And the new drug for glaucoma is nitarsudil. So just remember the names, at least nitarsudil. It is a Rho kinase inhibitor. It's a Rho kinase inhibitor. These are the drugs we use in glaucoma. Drug of choice is prostaglandin F2 alpha, which increase uveoscleral outflow. Fine. Now tell me the answer of this question. Which of the following agent is not used in the management of asthma? Which of the following agent is not used in the management of asthma? Phosphodiesterase inhibitor, steroids, beta agonist, cholinergic drug. Let's see who will answer this tricky question. The answer of this question is cholinergic drug. Okay. Phosphodiesterase inhibitor, they are used. Example, Theophylline, which we will discuss. Steroids, they are used. Beta agonists used like salbutamol, formoterol, they are beta agonists, they are used. Remember, we rather use anticholinergic drugs in the treatment of asthma. In the treatment of asthma, we rather use anticholinergic drugs, not cholinergic drugs. So the answer is D. So let's see what are the different anti-asthma drugs we know. Remember, in acute attack of asthma, we give bronchodilator. In acute attack of asthma, we give bronchodilator. Like mnemonic is Batman. Mnemonic is Batman. Beta 2 agonist. Can you tell me certain beta 2 agonists? Like salbutamol. But now the drug of choice has become formoterol. Now the drug of choice has become formoterol. Anticholinergic drugs like ipratropium. Heard about ipratropium? It's an anticholinergic drug. Tiotropium, theophylline, and magnesium sulfate. These are the drugs we give for acute attack of asthma. In prevention of asthma or chronic or persistent asthma, we give a controller therapy for prevention of another attack. So these drugs are known as anti-inflammatory drug. So if you control inflammation, another attack of asthma will be controlled. So first drug is mast cell stabilizer. I'll tell you how. See this diagram. How inflammation occurs in asthma? First of all, on mast cell, there is an antibody IgE. So antigen comes here, mast cell, they release mediator, which leads to bronchoconstriction. So what are the different anti-inflammatory drug? The first drug is mast cell stabilizer. Mast cell stabilizer, like they will have chrome word in them. You have to find which word? Chrome. Chromoglycate, nidochromyl. So you can easily identify anti-inflammatory drug. Then we have 5-lipoxygenase inhibitor, which will inhibit the formation of leukotrienes inside the mast cell. So the drug name is Ziluton. What is the drug name? Ziluton. Ziluton is 5-lipoxygenase inhibitor. Then we have leukotriene receptor blocker. These drugs, they will end with the word leucast. Any drug you know? Monteleucast, Zafirleucast. Monteleucast, Zafirleucast. Plus we have now monoclonal antibody. We have a monoclonal antibody that will block IgE. That will block IgE. Drug name is omalizumab, where IgE is located on the surface of mast cells. Mast cells, they release interleukin 5. The drug that block interleukin 5 is mepolizumab, reslizumab, and benralizumab blocks the receptor of interleukin 5. Okay. Then we have a drug that will block interleukin 4, dupilumab. I hope now you have understood all the drugs for asthma. Dupilumab. Lastly, we have a drug which will have all action. All action. All actions, which is the drug of choice, corticosteroid. Corticosteroid. So this is the all the anti-inflammatory drug in asthma. These are the anti-inflammatory drug in asthma in front of you. I hope you have understood. Never forget now. Now remember this thing in mind. You will solve all questions. So tell me the answer of this question. Tell me the answer of this question. So these are the anti-inflammatory drug which we have discussed now. Okay, monoclonal antibodies as well. So tell me the answer of this question. What is the mechanism of action of Xyluton? Ah, what is the action of Xyluton? The answer is it's a 5-lipoxygenase inhibitor. 5-LOX inhibitor. Now you know the answer. Which of the following drugs is used in emergency management of asthma, does not act by bronchodilator? So can you tell me which of the following drug is not a bronchodilator? Anyone? Just remember, Theophylline comes with a brand name Derifilin. Okay. So what do you think is the answer? Salbutamol, beta 2 agonist. Beta 2 agonists were bronchodilator. Ipratropium, anticholinergic, again a bronchodilator. Terifilin is theophylline, Batman. Batman mnemonic is finished. So what is the left? Hydrocortisone. Hydrocortisone is a corticosteroid. So corticosteroids are not bronchodilator. They are anti-inflammatory drug. They are anti-inflammatory drug. I hope now you have understood this point. है ना? चलो, next question. A patient was taking theophylline for all bronchial asthma. After starting another drug, symptoms of theophylline toxicity starts appearing. Which drug is likely to be affected? First point, what are the symptoms of theophylline toxicity? I will tell you. And which drug increases toxicity of theophylline? We will come back to this question. The answer we will see, what is the correct answer we will see shortly. So first point, what is the side effect of theophylline? Theophylline is present in tea and coffee. Theophylline is present in tea and coffee. Now tell me, if you drink excessive amount of tea and coffee, what will happen? Can you tell me what will happen in kidney? Excessive urination. When you drink excessive. What will happen in brain? Excessive consumption will lead to seizures. Fine. Third, what will happen on heart? In heart, if you drink excessive tea and coffee, the heart rate increases, palpitations occur, arrhythmias. What will happen on GIT? Excessive consumption of tea and coffee lead to GIT upset, like nausea, vomiting and diarrhea. Agreed? And okay, nausea, vomiting and diarrhea. Now why it occurs? Remember, why there is diuresis and seizure? Because in kidney and brain, theophylline block adenosine A1 receptor. This is a question. It blocks adenosine A1 receptor. Why GIT upset occurs? Because it blocks phosphodiesterase enzyme, PDE enzyme, phosphodiesterase enzyme. Lastly, why arrhythmia occurs? Arrhythmia occurs because of both reasons. Because of blockage of adenosine receptor, because of blockage of phosphodiesterase enzyme. Okay. Now, theophylline, it is metabolized by, how theophylline is degraded? Theophylline is degraded by CYP enzyme. With CYP enzyme, 1 for T like 1, theophylline. Theophylline is given in asthma. So can we remember CYP 1A? 1 is the first alphabet. So A means asthma. Theophylline is used in asthma. It is given metabolized by CYP 1A2. Just remember the word 1A. Now there are certain drugs which will increase the activity of CYP, reduce the activity of CYP. Okay. So which drug increase the activity of CYP and which drug reduce the activity of CYP? The drug which increase the activity of CYP will reduce the effect of theophylline because it will get rapidly degraded, and the drug which decrease the activity of CYP will lead to toxicity of theophylline. Now we know what are the toxic effects. So remember only 2 3 words, not exact. Remember two drugs. First is rifampicin. So I'll give you a mnemonic: GPRS. Graciofulvin. They are CYP enzyme inducers. Phenobarbital and smoking. They reduce the effect of theophylline. What about toxicity? We will write a mnemonic: okay. This is a very important part. First is ciprofloxacin. They reduce the activity of CYP. Omeprazole, cimetidine, allopurinol, and erythromycin. Now tell me, let's come back to that question again. Let's come back to question again and try to answer this question now. Let's try to answer this question again. Now let's see, some student have given a wrong answer. I hope now you will give the correct answer. Who will give me the correct answer? Who will give me the correct answer? Which drug is causing toxicity of theophylline? Toxicity? The toxicity mnemonic, okay. The answer is erythromycin. The answer is erythromycin. So I have given you this mnemonic. See this mnemonic. Here we are getting erythromycin. This is the answer. Not rifampicin, not griseofulvin, but we are getting an answer of erythromycin. So we can see here the answer is erythromycin. Good. Let's come to next question. Long-term use of which of the following drugs is related to development of tremors? Which anti-asthma drug causes tremors? The answer is salbutamol, beta 2 agonist. The drugs which are beta 2 agonist causes tremors. The drug which is beta 2 agonist causes tremors. Let's see the side effect of beta 2 agonist. These are the side effect of beta 2 agonist: 3T, 2H. The side effect of beta 2 agonist like salbutamol is 3T, 2H. Very commonly asked question. Tremors. Sir, why tremor occur? Very simple reason. Because they stimulate beta 2 receptor on muscles. On muscle. And if you stimulate beta 2 receptor on muscle, it leads to tremor. So what is the treatment of tremor? The treatment of tremor is beta blocker. Essential tremors, we give beta blocker like propranolol. Tachycardia, because they stimulate heart. Tachyphylaxis means rapid loss of effect. Tachyphylaxis means rapid loss of effect. They decrease potassium in blood, hypokalemia, but they increase glucose in blood, that is hyperglycemia. So these are the side effects of beta 2 agonist like salbutamol. Next question, let's see who will answer this question. Hydrochlorothiazide works by inhibiting which pump in the nephron? Anyone? Which transporter in nephron? Hydrochlorothiazide. Thiazide word is coming. Remember this word, thiazide. The answer is sodium chloride pump in early DCT, not late DCT, early DCT. The answer is B. Let me tell you, you will remember very easily. Let's talk about all diuretic. You know that this is a nephron. This part of the nephron, which is very thick, this is PCT. And here Which diuretic act? Which diuretic act? Here act carbonic. Here which diuretic act? Carbonic anhydrase inhibitor. They act on which part of the nephron? PCT. Example, acetazolamide. Okay. Now we have this descending limb of Henle, which is thin till now. So which diuretic act here? You will write osmotic diuretic. Example, mannitol. So this part of the kidney is known as descending limb of Henle. Okay. Now this part of the kidney is thick. Can we call it a thick ascending limb? Tal. I will write it for you. And this tal has two portions. The first portion of this tal is medullary portion. So there is one transporter which is inhibited, sodium, potassium 2 chloride. And here which diuretic act? Here loop diuretics act. So loop diuretic, they act on medullary portion of thick ascending limb. Thick ascending limb, medullary portion, sodium potassium 2 chloride transporter is inhibited by loop diuretic. Like example, furosemide. Now let's move ahead. Cortical portion of thick ascending limb and divide it here early part of DCT. Cortical portion of thick ascending limb and early part of DCT. Here we have a transporter, sodium chloride symporter, and this transporter is inhibited by thiazide. So we will write thiazide, they inhibit sodium chloride symporter in cortical portion of thick ascending limb tal plus early part of DCT. Now lastly, we have late part of DCT and collecting duct. Here in late part of DCT plus collecting duct, which diuretic act? Potassium pairing diuretic. Potassium pairing diuretic. They act on late part of DCT. What are the drugs we have? SEAT, spironolactone, eplerenone, amiloride, and triamterene. So I hope every diuretic is in front of you. Now can you tell me which diuretic acts on PCT of nephron? Acetazolamide. Ascending limb, osmotic diuretic. Medullary part of thick ascending limb, loop diuretic by inhibiting sodium potassium 2 chloride transporter. Cortical part, above part of thick ascending limb and early part of DCT, that is thiazide diuretic. So I hope see this diagram. Now tell me the answer. Okay, so the answer is thiazides, they act on early part of DCT, not late part of DCT. Very good. So these are the various diuretic I have written for you so that you can remember in the last part. Last point, you can remember all these things very fast. So this is written already. Now let's talk about which of the following is a carbonic anhydrase inhibitor. So the answer is acetazolamide. You know acetazolamide, carbonic anhydrase inhibitor. Hydrochlorothiazide, thiazide. Furosemide, loop diuretic. Mannitol, osmotic diuretic. Okay. So everything about carbonic anhydrase inhibitors. These are the three drugs you must remember. Next question. A patient presented to hospital with roadside traffic accident. So RTA happened. The patient has raised ICP. ICP's intracranial pressure has been increased. Okay, without hematoma. That means right now bleeding is not there. That's fine. Which of the following drug is preferred for the management of patient? What is the answer? Very good, shabash. The drug of choice for raised intracranial pressure is osmotic diuretic mannitol. Mannitol is the drug of choice, but yes, glycerol can also be used. But overall drug of choice is mannitol because all these drugs are osmotic diuretic. Okay? Now let's see what are the different types of edema or increase in pressure in the body occurs. Remember in heart failure, pedal edema occurs, and in lungs, pulmonary edema occurs. What is the drug of choice? The drug of choice is loop diuretic. In kidney failure, periorbital edema occurred, nephrotic syndrome. Again, the drug of choice is loop diuretic. In liver failure, ascites occurs. Here, the drug of choice is potassium sparing diuretic spironolactone. Okay, and in increased ICP, the drug of choice or cerebral edema, the drug of choice is mannitol. Now remember, in mannitol resistant cases, in mannitol refractory cases of cerebral edema, we give loop diuretic. But vice versa is not correct. Vice versa means beta? Vice versa means that in heart failure and kidney failure, we cannot go like this. Remember, this is not allowed. Only from right to left is allowed. It means mannitol. It is absolutely contraindicated in heart failure and it is absolutely contraindicated in kidney failure. Okay? So you can only go from right to left. From left to right, you cannot go. I hope you have understood. Mannitol is not given in heart failure and renal failure. Loop diuretic can be given in increased ICP if there is cerebral edema. I hope you have understood. Good. Let's move ahead. A patient with the history of heart disease presented with breathlessness, and you can see the images of the patient. Limbs are swollen. So which edema? And the patient is having heart failure. Tell me the treatment of this edema. So can we say because of breathlessness, the patient is having pulmonary edema, and this is pedal edema. What is the drug of choice? The drug of choice is loop diuretic. Now tell me the mechanism of action of loop diuretic. Loop diuretic inhibits sodium potassium 2 chloride symphoterin. This is the transporter which was inhibiting, but in thick ascending limb, which is a part of loop of enzyme. The answer is C. B. The answer is B. I hope you have understood. Now the questions are clinical based questions which are asked commonly. Okay. Now tell me emergency with ascites. What is the management? The answer we already know is spironolactone. The answer is spironolactone. Very good. Next question. A 28-year-old male went to Ladakh. Yes, after you clear your exam, you should also go. He developed shortness of breath. Which of the following drug would you like to use in the patient of mountain sickness at high altitude? What is the answer? What is the drug of choice for mountain sickness? The drug of choice for mountain sickness is carbonic anhydrase inhibitor. The answer is acetazolamide. So the answer is acetazolamide, drug of choice. So let's talk about all sickness. Mountain sickness, drug of choice, acetazolamide. Morning sickness, that means vomiting in pregnancy. The drug of choice is vitamin B6, that is pyridoxine. Plus, we add one antihistaminic drug, doxylamine. Plus, we add doxylamine. Motion sickness, I think we have already discussed. Already discussed. Antimuscarinic, like hyoscine, and antihistaminic. The names we have already written, you can see again from those slides, like promethazine, diphenhydramine, etc. So don't get confused between these sicknesses. Okay, very good. A professor in medical college is teaching students about the adverse effect of a drug. Which of the following drugs can cause gynecomastia in men and menstrual irregularity in female? Which diuretic causes gynecomastia? The answer for this question is spironolactone. The reason is spironolactone blocks testosterone receptor. Hence, in males, it causes gynecomastia and impotence also. It also blocks estrogen receptor. In females, it causes menstrual irregularity. But it has one use. Because it blocks testosterone receptor, it is used for treatment of hirsutism in females, which occurs in PCOD. Which occurs in PCOD. Fine. So which drug causes gynecomastia? Mnemonic is DISCO. First is digoxin. Second is isoniazid. Third is spironolactone because they block testosterone receptor. One antihistaminic drug given for peptic ulcer, cimetidine, antifungal drug, ketoconazole, and proton pump inhibitor, omeprazole. Omeprazole is a PPI, proton pump inhibitor. So these are the drugs which causes gynecomastia. Remember this point always. Next question. Drug of choice for the treatment of digoxin-induced ventricular arrhythmia. The answer is lignocaine. So just remember, arrhythmia is not a very important topic for FMG, but yes, few question comes. Atropine. It is the drug of choice for bradycardia. When the heart is beating less, then we give atropine and AV node block. Lignocaine, it is the drug of choice for digoxin induced ventricular fibrillation. Digoxin induced ventricular fibrillation. Amiodarone is the drug of choice for ventricular fibrillation after MI. Okay. Plus, it can be given in all other types of arrhythmia. All arrhythmia we can give amiodarone except one. Except long QT syndrome, which is can write as torsades de pointes. So what is the treatment of torsades de pointes? In the treatment of torsades de pointes, we give magnesium sulfate. Magnesium sulfate. Prokinamide, it is given in the treatment of treatment of WPW syndrome, Wolf, Parkinson, White syndrome. There are two drugs which are given in WPW syndrome, procainamide and flecainide, to control arrhythmias. These are the MCQs you must remember. Lastly, one more drug we should remember, adenosine. Adenosine is one antiarrhythmic drug which is given in the treatment of acute attack of PSVT. PSVT is paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia. So just remember this part. Your questions will not come out of this slide. Okay. So drug used for the treatment of pregnancy induced hypertension. Now, what is the treatment? Anyone? What do you think is the treatment? What is the treatment? Let's see. Drug used for the treatment of pregnancy induced hypertension. The answer for this question is hydralazine. This was a tricky question. That is why I have put this question. The answer is C, hydralazine. Let me explain you. You will understand it better now. Suppose, sir, there is a female who is hypertensive and she became pregnant. This disease is known as chronic hypertension in pregnancy. Chronic hypertension in pregnancy. Here the drug of choice is alpha methyl dopa. And if it is not controlled, we give labetalol. Fine. Now let's see another scenario. There is a female who is normal. She became pregnant and after 20 weeks of gestation, the blood pressure increased. And the blood pressure increased very high. Blood pressure increased very high. This is known as PIH. Can you tell me what is PIH? Pregnancy induced hypertension. Here the drug of choice is labetalol. If it is still not controlled, we give nifedipine. If it is still not controlled, we give hydralazine. I hope you have understood. Alpha methyl dopa is not a very effective drug actually. And in PIH, the blood pressure increase very high. It is uncontrolled increase. Done? So you will go by the answer hydralazine. Now remember, ACE inhibitor and AT1 receptor blocker, they end with the word sartan. ACE inhibitor, they end with the word pril. AT1 receptor blocker, angiotensin 1 receptor blocker, they end with the word sartan. They are absolutely contraindicated in pregnancy. We never give ACE inhibitor. We already discussed this. Okay, we never give this drug. Fine. Next question. A 56-year-old patient with a known case of hypertension is being treated with antihypertensive drug. He is having chronic cough, hypertension, antihypertensive drug. He was started on antimicrobial, but cough did not resolve. Antimicrobial cough did not resolve. That means this is non-infective cough. This is non-infective cough. Which drug? Remember, ACE inhibitors, they increase bradykinin level and they cause chronic cough. Hence, they cause chronic cough. So, ACE inhibitor, remember, they inhibit the conversion of angiotensin 1 into angiotensin 2. Angiotensin 1 into angiotensin 2. And ACE inhibitor, they inhibit degradation of bradykinin. Because of this reason, ACE inhibitor, they increase bradykinin level because ACE enzyme is required for degradation of bradykinin. Hence, ACE inhibitor increase bradykinin level and ACE inhibitor produce a side effect daru. Remember a word daru. D for dry cough, which was asked in the question. Second is angioedema. We can say swelling of face, lips. This is angioedema caused by ACE inhibitor. ACE inhibitors, they end with the word pril, like captopril, lisinopril, etc. Or any drug ending with the word pril is a ACE inhibitor. Rhinitis and urticaria. Fine. A hypertensive patient was started. Again, same question. Developed dry cough. So the answer is ACE inhibitor. Again, a repetitive question. Next question. A person was having a history of angina and the angina, heart rate of 90 beats per minute. That means normal heart rate. And it has a tense personality, anxious personality, anxious, angina, and blood pressure is high. The preferred drug for the treatment of hypertension in this patient. Let's see who can answer this question correctly. Drug of choice for hypertension with angina. Who will tell me the correct answer? The drug of choice for hypertension with angina is beta blockers. So I will tell you all the drugs for angina. The answer is metoprolol. So remember, hypertension with angina. The drug of choice is beta blocker. And beta blocker also decrease anxiety level also. That is why propranolol is given in performance anxiety. I have already told you. Yes, beta blocker. So let's see. First type of hypertension known as essential hypertension. In essential hypertension, let's say there is no comorbidity. That means the patient is having no associated disease. The patient is only having hypertension. The three drug of choice first line drugs are CAT. C for calcium channel blocker DHP type, which ends with the word dipine, like amlodipine, etc. ACE inhibitor ending with the word pril, or AT1 receptor blocker. If there is dry cough, we start over AT1 receptor blocker, sartan, and thiazide diuretic. Okay, so remember dipine, three word, dipine, pril, ACE inhibitor, AT1 receptor blockers, sartan, and thiazide. These are the drug of choice for hypertension. You can start any one of the following drug and add other drug. But if the patient is having some comorbidity, the drug of choice will change. So if the patient is having hypertension with comorbidity, then the drug of choice will change. So if the patient is having any heart disease like angina, hypertrophic obstructive cardiomyopathy, aortic dissection, atrial fibrillation. So the drug of choice in this case will become beta blocker, because beta blocker, they will suppress heart also. Additionally, beta blocker are also given in migraine and hyperthyroidism associated with hypertension. Even if the history of anxiety is not given, even only if stable angina word is written, hypertension with angina, drug of choice straight away beta blocker. because beta blocker protect heart also. They are the first line drug for angina also. So one drug will cure both things. That is why. So here the drug of choice will change. Now can you tell me the drug of choice in all these condition? Hypertension with renal failure. How we diagnose renal failure? Microalbuminuria. Hypertension with diabetes, metabolic syndrome, stroke, retinopathy, scleroderma, anyone. In all these conditions, the drug of choice with hypertension, with CKD and etc., the drug of choice is ACE inhibitors. Here the drug of choice become ACE inhibitor. But remember, ACE inhibitor is avoided in black people. We don't give ACE inhibitor in race, black race. The effect is not very good. Okay. Now, can you tell me in all these conditions, hypertension with peripheral vascular disease like Raynaud's disease, renal artery stenosis, the drug of choice is only these two you have to remember is calcium channel blocker DHP type. These drugs they end with the word dipene. They will end with the word dipene. Okay, very good. So remember, this notes will be provided to you. Which of the following statement is true regarding L-chirin? It is contraindicated in diabetes mellitus. Now remember one point. L-chirin is a new drug, and I will tell you what this drug and its uses are like ACE inhibitor. Its uses are like ACE inhibitor. Now tell me. It is contraindicated in diabetes mellitus? False. ACE inhibitor are the drug of choice for diabetes and hypertension. Do we give ACE inhibitor in pregnancy? Again, false. It is absolutely contraindicated. It is, sorry. It is absolutely contraindicated in pregnancy. Okay? It is absolutely contraindicated in pregnancy. It increases aldosterone level? False. I will tell you it will reduce the level of aldosterone. Okay? It indirectly increases renin level. This indirectly increases renin level. Now this statement is also false. I think there is some misprint. Which is the true statement. It is contraindicated in diabetes. Can be given in pregnancy? False. Increases aldosterone level? False. It indirectly increases renin level? False. All statements are false. Okay. Now let's see the question. Probably a misprint which has been given to me. Now let's see what is this L-chirin. Okay. See, you know RAS inhibitor, renin, angiotensin aldosterone system. This is what RAS is. Angiotensinogen gets converted into angiotensin 1 with the help of renin. Fine. Then angiotensin 1 gets converted into angiotensin 2 with the help of ACE enzyme. Angiotensin 2 acts on AT1 receptor and it increases aldosterone secretion. So the first drug is direct renin inhibitor L-chirin. How we can remember? I means inhibiting renin. Second, ACE inhibitor. Third is AT1 receptor blocker. Okay? All these drugs are same drug. So can we say that L-chirin it decrease aldosterone level? It decreases aldosterone level. This point I wanted to tell you. And ACE inhibitor are contraindicated in pregnancy. ACE inhibitor is contraindicated in pregnancy. And ACE inhibitors, we know they are decrease aldosterone level and it decreases renin secretion. So must be some misprint. Let's forget that point. Now a 50-year-old male present with acute chest pain. A preliminary diagnosis of acute angina was made and nitroglycerin was given sublingually. The pain was relieved in 5 minutes. What is the action, mechanism of action of nitroglycerin? Nitrate word is coming. We all know nitroglycerin release nitric oxide. It release nitric oxide. Let's write the names of all vasodilators. There are three types of vasodilator. First is potassium channel opener. They dilate artery. Potassium channel opener, they dilate artery. So the drugs are MDH. Remember MDH. Minoxidil, diazoxide, hydralazine. And write a mnemonic namak. MDH ka namak. Okay. Minoxidil is given in the treatment of alopecia also. Diazoxide is given in the treatment of insulinoma also. Hydralazine is metabolized by acetylation. It's a part of ship drug. Nicorandil is given in the treatment of angina. Now we have vein dilator, which will dilate vein, and a combined dilator which will dilate both artery and vein. We have nitrate and nitroprusside. Nitrates and nitroprusside, they are nitric oxide donors. These drugs are nitric oxide donors. Nitroprusside is given in the treatment of hypertension. Nitrates are given in the treatment of angina, MI, and hypertension. Angina, MI, and hypertension. Fine? Easy to remember? Remember this point in the last moment. All the questions will be solved. A 44-year-old man admitted to ICU after being diagnosed with subarachnoid hemorrhage. Wherever this word comes, subarachnoid hemorrhage, don't forget one drug. Which drug? Nimodipine. Okay. Secondary to ruptured aneurysm. This patient is a stage 2 hypertensive taking Ramipril. Which of the following calcium channel blockers can be used in this case, which may relieve cerebral vasospasm? So the answer is nimodipine. Don't forget this word. Nimodipine is the drug of choice for subarachnoid hemorrhage. Why? Because nimodipine crosses blood-brain barrier. Hence it is known as cerebro-selective calcium channel blocker, and it dilate cerebral arteries. What happens in subarachnoid hemorrhage? There is cerebral vasospasm. In subarachnoid hemorrhage, there is cerebral vasospasm which kills the brain. Hence, we dilate this cerebral artery with the help of nimodipine. Very, very important topic. Okay, good. Very, very important. So, what is the drug of choice for acute attack of PSVT? I think we have already discussed. The answer is adenosine. Which antiarrhythmic drug in PSVT? Adenosine. Fine. Next, a female patient was taking warfarin for prosthetic heart valve. She became pregnant, and which advice would you give regarding the use of this drug in pregnancy? Let's see who will answer this question. Continue warfarin without any concern. Continue warfarin but add vitamin K. Change warfarin to heparin, or you will terminate the pregnancy. What is the answer? The best answer we have already discussed. Warfarin is contraindicated in first trimester of pregnancy. We must change warfarin to heparin. We must change warfarin to heparin. Very good. Okay. So why drug of choice for anticoagulant in pregnancy is low molecular weight or ultra low molecular weight heparin. Warfarin is contraindicated in first trimester up to 12 weeks. because it causes vitamin K deficiency in fetus. Vitamin K deficiency leads to bone and cartilage defect. Just remember, bone and cartilage defect in fetus, because vitamin K is required for bone formation. Vitamin K produce osteocalcin, which is required for bone formation. So just remember this word, bone and cartilage defect with warfarin, known as chondrodysplasia punctata, also known as fetal warfarin syndrome. So you can see a saddle nose in this child, saddle nose. So this is produced by warfarin. Saddle nose is produced by warfarin. Warfarin can be started after 12 weeks. Okay. A patient with valve replacement therapy. Now remember, drug of choice for patient with valve replacement is anticoagulant warfarin. If a patient is having valve replacement, artificial valve, we can remember a word, warfarin. So warfarin is the drug of choice in patient of valve replacement, because valves, artificial heart valve, they can increase clotting factor activation, which can lead to hypercoagulation. Okay. So beta, warfarin is contraindicated in third trimester also. First trimester only, second and third we can give, and before 1 day delivery we stop warfarin, because during delivery we don't give any anticoagulant drug, because it can increase the risk of bleeding during delivery, postpartum hemorrhage. Now what is the action of TPA? What is TPA? TPA stands for tissue plasminogen activator. The function of tissue plasminogen activator is to convert plasminogen into active form plasmin, and plasmin degrades fibrin. Plasmin degrades fibrin. So now can you tell me what is the mechanism of action of TPA? Drugs are, the answer is fibrinolysis. The answer for this question is fibrinolysis. So what are those drugs? The drugs are L-tiplase, retiplase, and tenecteplase. Tenecteplase. Now one additional point, we have a drug which will inhibit this process. These drugs are known as antifibrinolytic. So these drugs are known as fibrinolytics. The drug which inhibit this process is antifibrinolytics. The drug is tranexamic acid. So they are opposite of L-tiplase and tenecteplase and amino caproic acid. Amino caproic acid. So these are opposite drug which will inhibit this process. Remember the name of these drugs? Very important. Next question. This is a diagram I have made for you so that you can understand this diagram. Fibrinolytics, TPA, they convert plasminogen into plasmin. Plasmin degrades fibrin. Plasmin degrades fibrin. Good. So which of the following drug is an oral direct thrombin inhibitor? Who will tell me the answer? Oral direct thrombin inhibitor. The answer for this question is dabigatran. The answer for this question is dabigatran. Let me tell you how to remember the names of all anticoagulant drugs. You know there are two types of coagulation pathway: extrinsic pathway, intrinsic pathway. Extrinsic starts from 7, merge on 10. Intrinsic starts from 12, merge on 10. 10 activates Factor 2, thrombin. Thrombin causes fibrin deposition. Anticoagulant drug, they inhibit fibrin deposition by inhibiting this pathway. Anticoagulant drugs are of two types, oral anticoagulant and injectable or parenteral anticoagulant. Among oral anticoagulant, the first class of drug we have is warfarin, a vitamin K antagonist. These drugs are known as coumarin. These drugs are warfarin, acetylcoumarin. So these drugs, they inhibit which clotting factor? 2, 7, 9 and 10. Vitamin K is required for 2, 7, 9 and 10. Second oral anticoagulant is which will inhibit this factor 10. Factor 10 inhibitor. These drugs will end with the word exaban, like apixaban, rivaroxaban. Exaban word is coming by 10A. Then we have direct thrombin inhibitor, oral drug. The drug name is dabigatran. How to remember dabigatran? Very easy. D for direct, TR means thrombin, AN means antagonist. So these are the three oral anticoagulant drug we have. Then in injectable we have indirect thrombin inhibitor. And again direct thrombin inhibitor. Among direct thrombin inhibitor, we have drugs, they end with the word riodin. These drugs, they end with the word riodin, like periodin, leperiodin, vivaliriodin. You can understand riodin word? One drug is name is different. Try to remember ergotroban. So they are injectable direct thrombin inhibitor. Then we have indirect thrombin inhibitor, which will activate some protein antithrombin in the blood, and antithrombin will inhibit thrombin. So they are indirect thrombin inhibitor, heparins. So this is the complete list of, okay, which are given anticoagulant. Now, purpose of adding zinc to the insulin. Anyone? When we add zinc to the insulin, remember insulin molecules, they attach over zinc. Insulin molecule attach over zinc, and this insulin takes more time to get separated, to separate and absorbed into blood. That is why zinc makes insulin longer acting. Zinc makes insulin longer acting. And we have a zinc insulin. The name of that insulin is regular insulin. Regular insulin contains zinc, which makes insulin a little bit longer acting. So zinc is added to the insulin to make it longer acting. Good. Fine. Next question. Exenatide is a new drug used in diabetes mellitus. Mechanism of action of this drug. Now remember, any drug in diabetes which is ending with the word natide or glutide. Any drugs in the diabetes which is ending with the word natide or glutide is GLP-1 analog. GLP-1 stands for glucagon, like peptide 1 analog. So can you tell me what is the answer? Can you tell me what is the answer? The answer is GLP-1 analog. Any drug which is ending with the word gliptin is a DPP4 inhibitor. So answer for our question is B. B is the correct answer. So any drug which ends with the word gliptin is a DPP4 inhibitor, dipeptidyl peptidase inhibitor. Now, any drug which reduce the absorption of carbohydrate, acarbose, voglibose, fine. And the drug which are PPAR gamma stimulator, they will end with the word glitazone. Can you tell me any name, any drug with the ending with the word glitazone? Any drug? Pioglitazone, rosiglitazone, etc. Okay. So these things I have told you lectures also, so you can just remember. So these are the drugs we are having in diabetes. So I will tell you a trick how to remember the name of drug. First drug in diabetes is acting at pancreas, acting at peripheral organ. Acting at pancreas, SMAID. Sulfonylurea, they will either end with the word amide or they will start with the word glee. If I say chloropropamide, tolbutamide, that will be sulfonylurea. Glipizide, glimepiride, gliclazide, sulfonylurea. Any drug that ends with the word glenide will be meglitinide, natiglenide, rapaglenide, ripaglenide. Amylin, AML word is coming. Only one drug, pramlintide. You have to remember the name. The question on name of the diabetic drug comes very commonly. GLP-1 analog, nartide, glutide, like liraglutide, exenatide. Okay, DPP4 inhibitor, gliptin, linagliptin, sitagliptin, bigonide, metformin. Okay, thiazolidine glitazone, SGLT2 inhibitor, flozin, canagliflozin, dapagliflozin, SGLT2 inhibitor, that is sodium glucose transporter inhibitor. This is a trick how you should remember the name of the drugs. Okay. Now tell me, which of the following anti-diabetic drug does not require dose reduction in renal failure? This question has been asked more than 20 times. So remember, which gliptin means DPP4 inhibitor. Which DPP4 inhibitor is safe in renal failure? There are two DPP4 inhibitor which are safe in renal failure. The first is linagliptin. So the answer of our question is linagliptin, and a new drug, tedigliptin. New drug, tedigliptin. They are renal safe. They do not require any dose reduction in renal failure. Now, Akhil, what is the action of PPAR? Yes, beta, Akhil, newer TB drugs. Next part we will discuss. Next on Monday we are having another class, and antimicrobial, autocoids, CNS, anti-cancer drugs will be discussed next day. Okay. Now, one student Akhil asked that before Akhil once asked that what is the action of PPAR? PPAR stands for peroxisomal proliferator activating receptor. Full form we don't have to remember. PPAR receptor is present in adipose tissue. See my lectures where I have explained you very nicely also. So it is present in adipose tissue. Now, in the presence of insulin, this PPAR receptor becomes stimulated, and on the surface of this adipose tissue, GLUT4 receptor comes. It leads to production of GLUT4 receptor, and hence glucose will enter into adipose tissue. And this is the action of insulin. So can we say this drug, pioglitazone, which is PPAR gamma agonist, improves the action of insulin on adipose tissue? Hence, it reduces peripheral resistance of insulin. So blood glucose will reduce, they will go into fats, the person will become obese also. Okay. Now, a 50-year-old type 2 diabetic patient was controlled on oral hypoglycemic agent. The patient had profuse sweating and dizziness. Can you tell me why profuse sweating and dizziness occur? Because of hypoglycemia, which is already given out here. Which drug in diabetes causes hypoglycemia? Anyone who can tell me the answer of this question? There are only three drugs in diabetes which can cause hypoglycemia. Anyone? Metformin, voglibose, vildagliptin, and glipizide. What is your answer? The answer of this question is glipizide. Now just write the list of the drugs which produce hypoglycemia in diabetes mellitus. The first drug is insulin. Any drug which is ending with the word amide or starting with the word gly is a sulfonylurea. Second class of drug is sulfonylureas. And any drug which is ending with the word glenide is a meglitinide. These two classes of drug, they increase insulin secretion from beta cells of pancreas, and increase in insulin secretion causes hypoglycemia. So let me give you certain example. Amide like chlorpropamide, you will find this MCQ. Tol butamide. Fine. What drug we had here? Can you tell me which drug we had here? Glipizide. So remember, glipizide. Glipizide is a sulfonylurea. Gliclazide. It is also a sulfonylurea. You'll write repaglinide, natiglinide, natiglinide. So this is a trick how to remember the drugs which produce hypoglycemia. In the management of diabetes mellitus, lactic acidosis is caused by which drug? Which drug in diabetes causes lactic acidosis? Tolbutamide, sulfonylurea, no. Glipizide, no. Pioglitazone, metformin. What is your answer? Which drug in diabetes causes lactic acidosis? The answer for this question is metformin. Metformin causes lactic acidosis. It also causes megaloblastic anemia. Why? Because it reduces B12 absorption from GIT. Pioglitazone, it increased the risk of urinary bladder cancer. Tolbutamide and glipizide are sulfonylurea. Their main side effect is hypoglycemia. Their main side effect is hypoglycemia. We already discussed. Now, why metformin causes lactic acidosis? Question is different. Because metformin inhibit hepatic gluconeogenesis. What is the action of metformin? Metformin inhibit hepatic gluconeogenesis. Hepatic gluconeogenesis means to convert lactic acid into glucose is hepatic gluconeogenesis, and metformin inhibits this point. Hence metformin increase the levels of lactic acid in the blood because it causes lactic acidosis. Causes lactic acidosis. Understood this point? Next question. Hormones and endogenous substance regulation of calcium balance. Very simple question for FMG student. I hope you all can answer it. Which three hormones you know? Acton, vitamin D, parathyroid hormone, and calcitonin. Okay? Calcitonin. Fine. Calcitonin. This question was previously last year asked. Which of the following drugs can be used in the treatment of undescended testes? The answer is testosterone. If there is testosterone deficiency, we can give for the treatment of undescended testes. Okay. Next, a patient was operated for prostate cancer. You know that prostate cancer is testosterone dependent cancer. And during surgery, local metastasis was noticed. Which of the following drug the patient should receive? Now remember, the drug of choice for prostate cancer is nowadays is gonadotropin releasing hormone agonist. First class of drug which we give for prostate cancer, they are the drug of choice. I will tell you the name of the drug. Uprolide, Gosrelin, Istrelin, Usrelin. All are ending with the word Renlin. First, Luprolide is the drug of choice. The reason is gonadotropin releasing hormone agonists, they reduce the production of testosterone when given continuous injection. Continuous injection, not intermittent. Second drug which we can give is gonadotropin releasing hormone antagonist. So they were ending with the word relin. It will end with the word relics, like cetorelix, digarelix, abarelix. But remember, the drug of choice is agonist because continuous stimulation of gonadotropin releasing hormone receptor decrease the production of FSH and LH, which will further reduce the production of testosterone hormone. So the answer for our question is Luprolide, very commonly asked question. Answer for the question is Luprolide. What is desmopressin? It is ADH hormone. Octreotide, somatostatin hormone. Tamsulosin, we already discussed, alpha 1A blocker. We already discussed alpha 1A blocker. So Luprolide is the drug of choice. Another drug is Relix wale drug, can also be given in prostate cancer. Now the drug of choice for hyperthyroidism in third trimester of pregnancy. Anyone? We have already discussed. The answer for this question is carbimazole. I will tell you the reason for it. So hyperthyroidism, if in pregnancy, if hyperthyroidism occurs in first trimester, we give propylthiouracil. Second and third trimester, carbimazole and methimazole. Okay? Now, PTU is contraindicated in second and third trimester. The reason is it is hepatotoxic. And carbimazole and methimazole, they are contraindicated in first trimester because they are teratogenic. And in teratogenic, they produce aplasia cutis. So remember, you cannot exchange these two drugs. First trimester drug is different. Second and third trimester drug is different. Okay. Isotope of iodine used in thyroid cancer. Anyone? The isotope of iodine used in thyroid cancer is iodine 131. 123 and 125, they are used in imaging. But iodine 131, it emits beta rays. They emit only alpha rays. Beta rays destroy thyroid cells. Hence, because it destroys thyroid cell, it is used in the treatment of thyroid cancer. Because it destroys beta rays destroy thyroid gland. Remember this point. Good. A patient presented with following features: chronic intake of a drug for several years. What do you think the patient has consumed? Can you see? A patient is having fat belly. We can say moon-like faces. ठीक है? Obesity. Fine. There is skin striae, skin damage. There is hyperpigmentation in skin. And there is osteoporosis in bone. Anyone? Which drug produce these all symptoms? These are the symptoms of Cushing syndrome. Cushing syndrome is caused by corticosteroid. Cushing syndrome. So these are the features of Cushing syndrome. A person will become very obese. Now, a patient on oral steroid therapy for last 10 years now developed progressive loss of vision in both eye. What is the most likely reason? Cataract, glaucoma, cystoid macular edema, or retinal detachment. Now remember one rule of corticosteroid, that oral steroids causes cataract, while same topical steroids, topical eye drops of steroids mainly produce glaucoma. Fine. Now tell me, what should be your answer? What should be your answer? The drug of choice for Cushing syndrome. It depends upon it is drug induced Cushing syndrome, stop the drug. If it is because of a tumor, which I will be telling you in anti-cancer drug, we give two drugs, either metotane or metirapon. These drugs, they inhibit metotane or metirapon. If this Cushing syndrome is because of tumor of adrenal gland, because these two drugs will reduce the production of corticosteroid from adrenal gland. But remember, the most common cause of Cushing syndrome is not tumor. It is iatrogenic. When a doctor prescribes a drug, we take corticosteroid. That corticosteroid intake as a drug causes Cushing syndrome, most common cause. Best treatment is stop that drug. So what is the answer? Oral word is written out here. Oral, we match with cataract. Why? Because here oral steroid word is written. If it would have been a topical drug, then we would have gone by glaucoma. Now, which of the following drug is given for the mother for delivering of premature baby for fetal lung maturation? Remember, for fetal lung maturation, the drug of choice is corticosteroid, and that is dexamethasone. Second is betamethasone. Because corticosteroid, they increase surfactant production. They increase surfactant production in fetus. That is why dexamethasone, betamethasone. Okay, dexamethasone, betamethasone. Now, which of the following drug is a selective estrogen receptor modulator? Now remember, short form of this selective estrogen receptor modulator is SERM, SERM. And remember, any drug that ends with the word phene or phene, you can pronounce phene or phene, is a SERM. It is an SERM. Now tell me which drug I am talking about. Which drug I am talking about? We are talking about tamoxifen. In India, we use Dexa. Out of the India, we use Beta. You are going appearing for Indian exam now. That is why we have written dexamethasone. If you would have been appearing for USMLE exam, I would have told you betamethasone. But you are appearing for Indian exam. Okay? India Dexa. Tamoxifen. Anastrozole, remember it is aromatase inhibitor. Mifepristone, it blocks progesterone receptor. It blocks progesterone receptor. Okay, it blocks progesterone receptor. Now this is a slide I have made for you. You can see later on also. What are the different SERMs? Tamoxifen, raloxifene, bazidoxifene, clomiphene, ormeloxifene, ospemifene. So you can go through these notes one by one. Tamoxifen given for breast cancer. Raloxifene given for postmenopausal osteoporosis. Okay. Their side effect is thromboembolism and flushing. Tamoxifen increase the risk of endometrial cancer. Raloxifene, no risk of endometrial cancer. A new drug, fulvestrant, it is known as SERD, selective estrogen receptor down regulator. It is selective estrogen receptor down regulator. Okay. Okay. Down regulator. Then we have aromatase inhibitor. Aromatase inhibitor, they will inhibit the conversion of testosterone into estrogen. They are given in breast cancer, but which breast cancer? Postmenopausal breast cancer. So they are given in postmenopausal breast cancer. Remember this point. Fine. Good. So this slide will be provided. Now, what is the dose of mifepristone in medical abortion? Anyone who can tell me? Anyone who can tell me? The dose of mifepristone in medical abortion, 200 milligram. Let's talk about a term known as MTP. What do you mean by MTP? That is medical termination of pregnancy. In medical termination of pregnancy, we call the female, or medical abortion, we call the female on day 1. We call the female on day 1 and we give mifepristone. We give mifepristone 200 milligram. We give mifepristone 200 milligram. Then we call the female on day 3. We call the female on day 3. On day 3, we give a drug misoprostol. We give a drug misoprostol, which is prostaglandin E1. Which is prostaglandin E1. It will cause contraction of uterus and the fetus will be expelled. Now the dose of misoprostol is either 400 microgram, 400 microgram or 800 microgram. So this dose you have to remember. 400 microgram if you are doing abortion up to 49 days. But a female is pregnant up to 63 days. We give the dose of 800 microgram. We give the dose of 800 micrograms. Remember this point. Methotrexate now is not recommended for medical abortion. Earlier it was recommended. Now in India, we don't give methotrexate. It leads to incomplete abortion. Okay, it leads to incomplete abortion. Now, what is the drug of choice for neurogenic diabetes insipidus? Anyone? The drug of choice for neurogenic diabetes insipidus is desmopressin. That I will tell you. Neurogenic diabetes insipidus, it is also known as central diabetes insipidus. Again, the drug of choice is desmopressin. So just see diabetes insipidus. Neurogenic means diabetes insipidus means there is defect in ADH hormone. In neurogenic or central DI, the brain is not secreting ADH hormone. So there is ADH deficiency. ADH deficiency. So we give ADH hormone from outside. So the drug of choice for neurogenic DI is desmopressin. But you can also give chlorpropamide and chlorpromazine. Chlorpropamide is an anti-diabetic drug. Chlorpromazine is carbamazepine is an anti-epileptic drug because these drugs they increase ADH secretion. Hence, they are given in the treatment of neurogenic diabetes insipidus. Desmopressin is synthetic ADH. Okay, fine. Now, nephrogenic DI is a different disease. Here, ADH is present in the body, but it is not able to act on kidney. So, the receptors of ADH on kidney is different. Hence, there is no action of ADH on kidney. Here, the drug of choice is thiazide diuretic. Because thiazide diuretic have anti-diuretic effect in nephrogenic DI. But if this nephrogenic DI is because of lithium, we don't give thiazide. Thiazide, they increase toxicity of lithium. Here we give amiloride. Okay, so this is the treatment of DI, and this is half of the pharma we have discussed today. So I took a very less time of yours. I think just 3 hours, and we will have one more session. In the rest of the session, we will be discussing about the rest of the session. We will discuss about CNS, antimicrobial in great detail, anti-cancer, autocoids, EIT, and miscellaneous topics. In part 2, we will discuss. Okay, so go through this video. I know 3 hours sitting continuously is a tough job for you. I know, tough or sometimes tough, but don't worry. The videos is safe. Go through it again and again. You will understand everything very nicely. Yes, in next topic, I will be covering TB in great detail. The guidelines of TB has been changed. So we will discuss certain new terms in TB like pre-XDR TB, classification of second line anti-tubercular drug. Don't worry. We will discuss everything in great detail in the next session. So any doubt you have, you can ask me right now. You must be reading pharma. If you have any doubt, you can ask me here also. I'll be happy to answer. Or otherwise, if you have any doubt, you see this video again and post your doubt in the comment section. Post your doubt in the comment section, or simply what you can do, you can join either Instagram, Facebook, Telegram. Even the Telegram channel is also there. So you join PW MedED on Facebook. We have a group. You can ask me your doubts there. You can ask me on Telegram, PW MedED channel, or Instagram, whatever you like. Just type my name, tag my name, the notification will come to me and I'll answer it. Okay, thank you very much. Antihypertensive of choice in pediatric age. Antihypertensive of child and adult is same. There is no specific contraindication of antihypertensive in children. We use same drugs are given. In pediatric age, yes, if a patient is having HUS, let's say hemolytic uremic syndrome, most of the time what happens, the blood vessel becomes blocked. Most commonly we start with your vasodilators like calcium channel blockers, dipines, amlodipine, nifedipine, etc. They are given in adults also. Antihypertensive in children and adult are not different, they both are same. In acute kidney injury, this is hypertensive emergency. If any organ gets damage in hypertension, this is known as hypertensive emergency. The first drug we generally start is nicardipine in hypertensive emergency. But one drug we have specifically for to protect kidney, that is phenoldapam. Unfortunately, this drug is not available. So if the patient is having acute kidney injury with very high hypertension, the drug of choice is phenoldapam. Phenoldapam. If phenoldapam is not available, overall drug of choice for hypertensive emergency is nicardipine. Because nicardipine dilate blood vessel, blood supply to the kidney will increase. Hence, it will protect from acute kidney injury. Okay. Acute kidney injury, it will protect. Any vasodilator you can give. Drug of choice, phenoldapam, not given in the option, go by nicardipine. Okay. So you have any other option, just write it on comment box or tag me on these three channels which I have told you of PW MedED. I'll be very happy to answer. Any contraindication of CCB, calcium channel blocker. Remember, calcium channel blocker, if you talk about verapamil and diltiazem, they act on heart. Verapamil and diltiazem, calcium channel blocker, they act on heart and they suppress heart. If you talk about two types, one is verapamil and diltiazem. These two calcium channel blocker, they act on heart and they suppress heart. Hence, they are contraindicated in very simple and logical reason: bradycardia, AV node block, and any type of heart failure. We never give verapamil and diltiazem. We never give verapamil and diltiazem. Now, second type of calcium channel blocker are known as dipine. Dipine. Dipine, they don't act on heart. They are artery dilator. They are artery dilator. And remember, they don't have any contraindication. No contraindication. The only contraindication is hypotension. Why hypotension? Because they are used as anti-hypertensive drug. If the BP is very low, then we will not give dipines. You know? Okay. Yes, all CCBs can be given orally except one, two. Nicardipine, clevidipine are two CCB which are IV only. All can be given oral and IV, but remember nicardipine and clevidipine, they are only IV. Because they are only IV calcium channel blocker, they are only given in hypertensive emergency. They are only given in emergency. In normal hypertension, we will not give, because normal person with hypertension will not love to take an IV drug. There we give oral drug. So they are only given in nicardipine, clevidipine. They are only given in IV. And one additional point I will tell you: nicardipine is overall the longest acting. Clevidipine is overall the shortest acting drug among calcium channel blocker. Okay. Okay. Chalo, thank you very much. Enjoy your day. Read this session. Any problem, any doubt, ask me again. We will meet on Monday also. Goodbye.